Good morning, everybody. Thank you very much to Boston Scientific for their kind invitation. So my role today is to talk or to try to share with you some views about biophysics of pulsed field ablation. When we're talking about pulsed field ablation, we are talking a totally different paradigm. And actually, when trying to explain biophysics in pulsed field ablation, I found that the best way is just to compare with something that you are very familiar with, that is radio frequency, because actually PFA and radio frequency are not that different. They are completely different. We are talking about different things, but at the very end, we are talking about electrical current and electrical circuits, and actually electrical circuits are all the same. We are talking, with a generator, we have blood, we have an ablation electrode or multi-electrode ablation thing, but we are talking basically about the same. Radio frequency, we work in the 100 volts range, more or less, but when we talk about PFA, we are in between 800 to 2000 volts. We have here the first difference. The other difference is when we radio frequency, we apply for 30 seconds, 4 seconds, 60 seconds, but when we talk about PFA, we are in the range of milliseconds. And why? Why we are in the range of milliseconds? Because our big enemy in PFA is heat. And the only way to avoid heat, because we don't need heat for anything when we're talking about PFA, is just using very, very short times. So if for radio frequency, what we do is we make current to flow through our catheter. That current gets into the tissue, and we create resistive heating. We create heat that create a lesion, and that heating goes away from that area, and we create conductive heating, and there we have our lesion. With PFA, we are in a totally different scenario. We don't want heat at all. This is not a thermal lesion creation. We don't want heat. So we base our effect in something that is called electroporation, that I will explain a little bit later on. And so what we want is just to create a very powerful electrical field, very short in duration, but a very powerful electrical field, because we don't want to heat. So that very powerful electrical field for a very, very tiny amount of time creates a phenomenon, a biological phenomenon that is called electroporation. Electroporation is something very simple. When you put a lot of current for a short time through a membrane, a bilayer membrane, you create holes, pores. When you create pores, you have ions going in and out of that cell, and that cell dies. That's the effect that we want. That's the effect that we are looking for. That's what we wanted to produce. So when we play with electroporation, we have to play with two constant. From one side, we create an electrical field, and we create that electrical field for a certain amount of time. So when the electrical field is not very powerful, or the amount of time is not very much, we don't have anything. We increase one of the two, we get into the green area, we create pores, but those pores are not big enough, so the cells don't die. So if our pores are bigger, our cell gets electroporated and die, reversible and irreversible. First is reversible, and then you get into reversible. If you increase power intensity, or you increase duration, you go into the red area. That's where you produce heat, and that's the area where we don't want to be. So the same way we create lesion, we increase our amount of complications. So what we have to do is just create a trade-off in between effect and complication rate. And that's something what we do when playing around with the characteristics of the lesion. So I told you, I don't want any heat. So to avoid heat, I have to use very short duration. How can I give a lot of energy with short duration? We use pulses. And that's why when we apply radio frequency, when we apply pulsed field ablation, we give pulses in order to avoid heat. When talking about PFA, we have to count on principles. And the first principle of PFA is that the tissue response depends on many variables. All these variables that you see here, there are many variables that have, with radio frequency, you have one energy. With PFA, we have many ways of give energy. So when you put all these variables, you can group, some companies use this kind of 3 legs kind of aggregation of variables. So From one side, you have the catheter design. Different catheter design will have a different impact on lesion creation because the distance in between the electrode, how the electricity goes from one electrode to another, create different electrical fields. You have waveform. The characteristic of the waveform will induce different lesion, different pattern of lesion. And the third leg will be the workflow. Depending how you apply, how many times you apply, how you move your catheter, the design of your catheter, the lesion you're going to be creating is going to be totally different. So this is the whole play. We are not with radiofrequency. We have a design, we have we have an energy. Here we have many variables. So things are much more different than when we talk just simply about radiofrequency. So with PFA, we are in a totally different scenario. And we have examples. You know, when you see Pulsed early trial, the Impulse PEFCAF1 and PEFCAF2, you see that they all give energy and they all created acute pulmonary isolation, all of them. But then they realized that in the first case, with monophasic energy, they have a relapse rate of 45%. So they change the waveform, and they create just a relapse rate of 84. And they change again the waveform. By changing the waveform, you create a different energy, and you create a different effect. And this is because you have irreversible electroporation. You have reversible electroporation. Your lesion comes back. So the cell, at one point, it doesn't work when you apply the energy, but later on, the cells recover. So you have to adapt, optimize your waveform in order to create the effect you want to get. So this is limiting, but it's also extremely important, critical at the time of designing a PFA protocol, at the time of applying PFA. Each energy behaves a different way. But also, the cells respond in different way. Not all cells respond at the same time. Not all myocytes respond. Myocytes in between them respond similarly. But the neural cells, you know, the vascular cells respond differently, and respond differently to the same energy at different patterns of energy. So we need to check exactly how they behave. And finally, the same way. The energy is different, so the lesion depends a lot of all these variables, but the complication rate and the type of complication is going to depend a lot as well in the type of energy, how that energy is delivered. So in all the variables that I was introducing to you. So I have this very nice, this is come from a very nice review from 2021 Circulation Arrhythmia Electrophysiology. You see all the parameters that are involved in the waveform and how they have an impact on many critical areas, not only lesion size, muscle contraction, temperature rise, and many other things. So as a take-home message, I would say that lesion formation and complication are a complex phenomenon in PFA and depend on many factors that we have to consider. And the second thing, more importantly, each PFA behaves different and should be evaluated totally independently, because we are talking about totally different things. Thank you very much.
It is on us to believe or not to believe, and it is always easier to believe when there is some data. And I think for this FirePulse technology, we have acute remapping data after 3 months, right? So we know that this has been investigated, and they came out with the protocol of 8 lesions. So with other technologies, we are a bit more in the dark. It is not mandatory to always do remapping. Some do it, some don't. And then also about the applications, the number we should give. So yesterday there was a presentation, a sub-study of the INSPIRE trial, where they showed that more applications led to better outcome. But before, when I read the first draft of the study, I wasn't sure how many applications do you have to give. So you say different designs, different applications, but I think it needs to be investigated invasively to really know, because as you said, there is myocardial stunning. Nothing leads your guides your ablation anymore. As also Daniel said, it's not on us to decide the dosing protocol anymore. So we need clear instructions on how many applications to durably isolate a vein.
Yeah, definitely. And the problem is that this type of investigation, I mean, when you have this presentation, clinical presentation, doing a case, you say, okay, you see, all our signals have disappeared. We have the pulmonary vein isolated. Because, of course, they're going to be isolated. Acutely, they are isolated. But 2 hours later, we don't know exactly. And actually, the problem is that it's not only 2 hours. We we can have only even 24 hours to wait in order to see what happened. So acutely, we cannot say anything. We are trying to go around this thing, trying to find markers of reversibility and irreversibility at the acute phase. But I can tell you, we are working on it, but it's extremely difficult. And we are working with different parameters that we are not used to look at. But signal disappearing doesn't mean anything. Of course, it's disappearing, because if you don't get signal disappearing acutely, you can forget about that technology, because acutely it has to disappear. The problem is that electroporation is reversible or irreversible. If it's but right now, we don't have a clear marker to see reversibility acutely.
When we look at MRI data, for example, we look at many patients with MRI, we see when we have thermal lesions, there is a lesion after 3 months, 6 months, 12 months, whatever. When we look at the PFA data, we see an early effect in terms of edema, so there is some inflammatory effect or whatever, but then the late enhancement disappears over the time. The veins are still isolated, but it seems like we see a different lesion formation pattern. Is that what we see, maybe an effect of the thermal side effect, and this disappears, and then we have scar formation? Or is it a complete different approach? What do you think?
Yeah, the thing is that when you have a thermal effect, you destroy tissue, and that's very easy to understand. You produce heat, and that heat disorganizes the tissue, destructurizes the tissue, and that's it. With PFA, the cells get apoptosis, but the architecture of the tissue stays there. So the pattern of fibrosis is totally different. Actually, even when you take a look to those lesions, visually you see that those lesions have a different kind of, aspect. They are different. So we need to know more about the behavior MRI and to understand the process. We still don't know many things about that lesion formation. We know that those cells get destroyed, but the fibrosis that gets involved in that tissue that has not been desnaturalized, that a tissue that keeps their architecture, is going to be totally different. So we need to learn exactly how that tissue is going to behave in terms of fibrosis, how that fibrosis is going to distribute, and how you're going to look at that fibrosis how the gadolinium is going to get around that fibrosis in order to have clear data, to understand what you see in MRI. That's the problem, that the process is totally different.
Thank you very much, José Guerra. It was a very, very interesting talk. So, it's my pleasure to introduce Daniel Scherr to give his presentation about pulsed field ablation for atrial fibrillation, aspiring to an optimal workflow and complete patient management. Daniel, the floor is yours.
Thank you, Melanie, dear Christian. So, ladies and gentlemen, thank you for showing up in this number. I hope my presentation is not too basic for you, because all I'm going to try to show you is the way we treat our patients with PFA at our hospital, and I'd like to start a discussion on how you do it in your hospital. And the way I want to start out is with a bit of data, and these two figures of a paper we put together for Europace, which is accepted for publication and will be downloadable in the next couple of days. A state-of-the-art review on PFA headed by Julian Chun. Point number one, we all know that at the beginning of the PVI and the ablation of atrial fibrillation, academic medicine played a big role. Think of Michel Hassaguer, think of the isolation of the pulmonary vein. This was a great discovery. Now we are in a phase, I think, where we still contribute, but we should not underestimate the contribution of biomedical engineering and of our industry partners. And they've given a giant push to the PFA modalities. That's point number one. Point number two, we are still very early in the experience. We talk about first-generation devices for PFA, and there is more to come and improvements to come. And point number three, the most we have accumulated on is the pentaspline catheter, with 50K plus patients so far treated worldwide. Other companies, other modalities coming, but for the sake of my talk, I'm going to focus on the pentaspline catheter and the data accumulated with it. So you're all aware of the ADVENT trial, and you could say, well, PFA did just as good as cryo and RF. I say it did at least as good. And why is that? Remember that this is a first-generation device compared with second and third-generation cryo and RF devices. And also consider that the investigators in this trial did thousands of thermal ablation procedures before and were given the PFA catheter for the first time, showed also a nice decrease in procedure duration and ablation time. For the real-world data, I see a lot of us in the audience who are part of the Manifest registry spearheaded by Vivek Reddy, and that tells us a lot about the excellent safety profile of the pentaspline catheter and PFA in general, and also about the efficacy. Real-world data showing 80% success rate in paroxysmal AF. And a recent paper I really like a lot by Jean-Baptiste Desquercia and Dominique de la Rocca and 4 very experienced centers in Europe showing, I think, 3 very important points. Again, at least as good efficacy rate at 12 months with PFA, with the pentaspline catheter as compared to cryo, as compared to RF, the significantly decreased procedural duration, and as a third point, the decreased pulmonary vein reconnection rate and the first pass isolation rate, which is increased. Now, let me come to the workflow discussion and the way we treat our patients at our center. One of the things we still do is a pre-procedural CT, but I think any other imaging modality is fine. Some of you will use ICE, and we sometimes also do that. Some of you will do PV angios. I think it's important to use one imaging modality. We do a NOAC AM hold on the procedure day, and we heavily believe in same-day discharge. We have in- and exclusion criteria for the patients that are eligible for same-day discharge. Just to name you 2 as a social factor, the patient should, when he's discharged the same day, it should not be a single-person household, for example. But we have a number of other factors that we tap into before we decide on whether or not the patient is eligible for same-day discharge. And just for the medical history, to name you a few of the factors, or one of them, we don't want heavily obese patients, and we don't want patients with severe chronic obstructive pulmonary disease for same-day discharge. Now, this same-day discharge concept goes along with the deep sedation protocol, propofol protocol, to create a lean PFA workflow and to allow us to discharge the patients on the same day and to treat more patients with the same number of beds and the same lab capacity. Now, to continue on our own workflow, we give full-dose heparin 15 minutes prior to the procedure, and we initiate the deep sedation with protocol also 15 minutes prior to the procedure before we puncture the vein. Now, our workflow further consists of a sono-guided venous puncture, and I think this is mostly standard all across Europe. A venous closure device we introduce and we use systematically in our patients, and I want to highlight the Style AF study, which was a late breaker yesterday, first author Roland Tiltz, that compared venous closure devices with manual compression with significantly decreased ambulatory time, and I think a nice concept one may adapt when looking for a lean procedural workflow. And then, of course, we do entrance and exit block pacing. And one thing, if you are at the beginning or about to begin your PFA experience, I highly recommend is to map in those early cases, the first few cases, systematically do a pre- and post-ablation map. It's not only to confirm your lesion, but also to get your entire team on board. Remember, your nursing staff, if you work, for example, in an RF-based lab, they always see the nice images, the isolated veins, the circles, everything. You want to reconfirm to everybody and to yourself, and most of all to the patient, that this is also working in the PFA arena. A few cases at the beginning, I think, are a good investment of time. Now, what to do outside of the pulmonary veins? And there I remain a bit skeptical, optimistic but skeptical. Now, you remember Peter Kistler's study, the Coupler trial. I think it's a great trial, and we learned a lot out of the study. There are various sub-studies where significant other information was gained. But all in all, it was a trial of persistent AF ablation with radiofrequency comparing pulmonary vein isolation in one group with, in the other group, the addition of posterior wall isolation. And at least for the primary outcome of the main paper, there was no difference between group. And we as physicians may now jump to the conclusion that this is the fault of the energy, that it is RF that is bad, that is RF that's not working for the posterior wall. And at least myself and maybe some of you in the audience have had bad days where we have really struggled to isolate the posterior wall with RF. We have these days all the time. But that's a foregone conclusion, and that's a hypothesis to be proven. Maybe there is no value in systematically ablating the posterior wall in all our persistent AF patients. Now, it can be done, very easily and very feasible with single shot devices, with the pentaspline catheter. And we do that in selected patients, but, the proof of concept is still out there that the systematic isolation of the posterior wall is of benefit for our patient. Let me tap into another thing, and that is the new kind of primary endpoint of procedure time. So here also I remain a bit skeptical about procedure duration. We are already pretty good with the tools we have, whether it's cryo or RF. We do these procedures in an hour or less. And now with PFA and single shot devices, we may come down to procedure times of 25, 30, 35 minutes. But this should not turn into a race, of course. I think two things that are important here is these new tools, and especially PFA with the pentaspline catheter, allows us to standardize the procedure. All the operators or most of the operators in your group will be able to do the PVI, to do the procedure in about the same time. And I think standardization is important for all of us. The second thing, of course, is the learning curve. And it's a great thing to see how members of your group advance. And for example, I want to highlight one colleague of mine, member of our group, a pediatric cardiologist, who is an expert in doing SVTs, who is joining our lab 2 days a week. And, as a pediatric cardiologist and invasive electrophysiologist, he just learned to do the PFA procedure, I would say, in no time. So at the end of the day, our post-procedural workflow consists of an echo in the recovery, the restart of a NOAC 4 hours after the procedure. We check the ECG, the punctured site, and discharge the patients 6 hours after the procedure. Let me come in the last 2 to 3 minutes to future therapy options, and there are, of course, many. Some I want to tap onto is the RF wire for transseptal puncture. Again, many experts in the room on transseptal puncture, but think about this democratization of the ablation, of AF ablation, making it accessible to more patients and also more physicians, maybe also physicians who don't have the privilege, like most of you here in the room, to do this procedure several times a week or almost every day. So, it's about easing the procedure and just making it more accessible. Another thing is the introduction of mapping. Now we have nice single shot tools, and PF is of course working as a single shot tool. Should we systematically introduce mapping? That's still an open question. There is preliminary data out of Basel, Christian Sticherling's group, that showed that the investment of mapping, but maybe true integration, 3D electroanatomic integration of the PFA systems with new features, like really seeing online the shadow of your ablation, like seeing ablation field tags, seeing where you apply the lesions may help, and this certainly has to be investigated if it has the potential to improve our success rates. And finally, more data, and we are very proud that under the leadership of Pierre Jaïs, we are 7 hospitals that are investigating currently PFA versus RF versus the closed protocol in what I think is the largest randomized controlled trial ongoing in Europe, and it will be hopefully presented next year, maybe at this Congress or the ESC, and will report outcomes on single-shot PFA versus RF ablation. With that, I'd like to conclude. Real-world data of PF for AF ablation demonstrates high safety and efficacy and decreased procedure time. I think we've learned that over the last year or last couple of years. And workflow optimization and standardization should make all our lives easier and help more patients in the same time. And innovation, 3D mapping integration, and long-term data is on the horizon, and it's an exciting time to be in EP. Thank you very much.
Thank you, Daniel, for this very, very nice presentation. So the first question I have for our short discussion for the rest of the time. So you presented the data from Della Rocca that showed with the FARAPULSE catheter a PV durability of 80.9%. We have the data from Frankfurt where they show in patients coming back for reablation almost 90% isolated veins. And then we have Advent. And in this study, patients coming back for reprocedure have PV isolation rate of only 67%. So do you think this is also linked to the outcome of that study? And how can we even improve? So we see there's improvement. We can do better with isolating the vein. What are your key messages to get that done?
Well, I think this is an important question because pulmonary vein isolation or durable lesions are important to all of us. So, and most of all to our patients. So what I think, number one, PV reconnection is still an issue, also in the area of PFA. Number two, I think, because it was discussed before, Jose, my feeling as a clinician is that tissue contact is important, and you really have to give credit to investigators and centers that use, for example, ice already in the single-shot era to assess for tissue contact. And, you know, actually, this single-shot device has triggered us to use ice from time to time, also in our cases, to assess for contact. And number three, I see, of course, the new tools on the horizon, 3D mapping iteration that I've shown. And the hope is that with these tools, we will solve the problem of PV reconnection, or at least decrease it to a minimum amount.